while doing antegrade wiring, intentional intimal tracking. That is something which we have been talking, since the beginning of this session. But however good your intentions are, you might end up like this, even with your first wire. So this is a fielder XTR in a mid-RCS CTO. You can clearly see it is subintimal. What are the next options? You can pull back the same wire and redirect it. Or you can take a parallel wire, take another wire along the first wire. And next, or you just take a stingray or the first wire course and re-enter. And next is you just take an IOS catheter into subintimal space where the first wire is and take re-entry into the true lumen and going retrograde. So these are the options, when you are in that conundrum. So coming to parallel wire, so what determines at the juncture, which route you have to choose is the clarity of CTO exit site. Basically, distal vessel visibility on angiogram. So if you have a great distal vessel visibility, I think parallel wire is the best option among these options, since it is basically antegrade, and the success rate is quite good. And another thing is, the cost. When you compare with, laser. So when you compare with stingray, this parallel wire costs, 50% of stingray. And redirecting wire, but these three techniques which are here are mutually exclusive. If you try one technique longer, other two techniques doesn't work because of, subintimal space expansion. So that is something which we have to keep in mind. So, yeah, so this, okay. So in this case, you can see, the wire is clearly subintimal. So how parallel wire helps? Your first wire is already across. So what it does is it straightens your vessel a little bit based on the stiffness of the first wire. And next is your first wire is a roadmap for your second wire so that you can navigate second wire, much better fashion than the first wire. So that's all about, parallel wire. So, and you can take a W-lumen catheter, as already mentioned by Dr. Sudhir in the beginning, or you can take another microcatheter parallelly. This is a W-lumen catheter with which you can take a wire, and here, just take a microcatheter parallel to your first wire and then take another wire. So based on, your choice of microcatheter is decided by the size of the guide catheter which you have chosen to start with. Okay. Yeah, so the wire of choice, the presumption in this scenario when the wire is subintimal is your first wire, having hit a resistance in the CTO, went into a low resistant plane that is subintimal. So that is the presumption based on which, we make choices. So obviously, your next wire of choice should be something which breaks that resistance. So take a better tip load wire and obviously, more directable wire. So in this case, the first wire is fielder XTR. So hence, I escalate to, Gaia 2, either 2 or next 2, whatever is available. If the first wire itself is Gaia 2, you go to Gaia 3. So usually we escalate wire. Yeah, there are cases where we do de-escalate. And you can see here, my second wire is just going, and you can see here, directed in two orthogonal views. Always we take two orthogonal views and you direct. You can see here, the second wire is in true lumen against the first wire, which is subintimal. And you will achieve good result, without losing any side branches when you enter into the very proximal part of the distal lumen. And you can see another case, distal RCS CTO, you can see there is a good vessel even proximal to the PDA origin. And we tried fielder XTR, it didn't progress, so I had to escalate to Gaia 2. And you can see Gaia 2 is in subintima. And then I took parallel wire with W-lumen catheter, escalated wire to Gaia 3. But we shouldn't think always, we'll be successful with your next wire. So sometimes you may not be successful despite the good roadmap you have with the first wire. So that is what happened here. So advanced Gaia 3, but you can see even Gaia 3 is subintimal. So this situation can happen. Then you can use two wires, and you can navigate one wire using other wire as a roadmap. So you can use either wire, based on your wire advancement. So I used Gaia 2 now, and advanced Gaia 2 using Gaia 3 as roadmap. And finally, we reached distal true lumen. And you can see here we reached distal true lumen. And then, exchange wire, and then you finish your procedure. And you can observe here, see, the flap which is there in the PDA, that is basically created by Gaia 3. So these things can happen. I'll show you next case how parallel wire can even spoil your case as well. In an ambiguous cap scenario, how to do parallel wire? This is, again, important. See, an ambiguous oscillatory cap. So we did IVUS-guided cap puncture, that is first. And we confirmed, wire position. You can see here, wire is just sitting exactly, where that's a central wire entry. And once that is done, but the wire distally is subintimal. So how to do parallel wire here? See, we have to ensure our second wire also goes through the entry of first wire. There is no need to reconfirm again with IVUS. So to do that, so once the wire is in and you confirmed with IVUS, and then you just take a balloon, dilate it in the beginning, and take a W-lumen catheter so that the over-the-wire lumen is, this is over-the-wire lumen, is beyond the ostium of LAD. So that makes sure your second wire is also in the same entry which you have already confirmed with IVUS, and advance your second wire, as parallel wire using first wire as a guide, and you can be successful. So when parallel wire fails, so success is not 100% with parallel wire. So you can see this mid-LED CTO, ambiguous cap. We did IVUS-guided cap puncture, and then advanced first wire went subintimal. You can see here Gaia 2 is subintimal. So then we did parallel wire with the W-lumen catheter. Next wire was Gaia 2. And you can see even the next wire was subintimal. So I tried for nearly 10 minutes, but what happens after some time with these parallel wires, you can see the distal vessel is now almost very invisible. So that is what happens. I'll compare, I'll show you. This is where I started. This is how the CTO distal vessel was, and this is what, after parallel wire. So it can spoil your distal lumen. So then what to do? See, either you can go retrograde, or you can bring an IVUS catheter on those wires, and you can do, IVUS-guided antegrade wiring, or a tip detection ADR if you want to come from subintima to true lumen. So either can be done. So that's what we did. I took an IVUS. So you can see this is an IVUS catheter, and then parallel microcatheter with a Harnett wire. And you can see here, so this is a true lumen, and you can see this is the wire, which is going into true lumen. So you can do true lumen wiring, and subsequently, you can advance microcatheter into that true lumen, and you can de-escalate wire, and you can complete your procedure. You can see this is a wire which is in true lumen. So these are the options, which you can explore. See, you can see the final result is good. All the side branches are, filling despite, good subintimal space creation. So to conclude, parallel wire is undoubtedly, unparalleled. So with a good success rate. And the most important determinant is the clear distal vessel, which makes, your success more predictive. And These three techniques, parallel wire, redirecting your first wire, and device-based reentry, are mutually exclusive since they create subintimal space. And second wire in parallel wire is generally high tip load wire than the first wire, but sometimes we may de-escalate. Doubleman catheter can be used, but needs multiple exchanges. In ambiguous cap, doubleman ensures second wire through the same cap entry, which you achieved under IVIS. And be prepared for next strategy if parallel wire fails. Thank you.